New Jersey. I'm going to speak in English, but because my Italian is okay, not good enough, I don't think, to communicate. I'm currently in a private practice, and about 95% of the patients that I see have pandas. So we have a personal and very large experience with this disease, and my background really is a scientist, so we try to look at this disease scientifically and try to see if we can understand the basis of it. When I usually give this talk, it's so long that I have only 2 seconds to talk about the summary, so I decided to do it backwards and tell you what I'm going to be talking about. Pandas is a common disorder of childhood. We don't really know the incidence, but I could guess it's somewhere in the range of 1 in 200, 1 in 100, somewhere in that ballpark. So it's close to the incidence of epilepsy, or lifelong incidence of epilepsy. So it's definitely not a rare disease. So that's a myth. It should not really be an orphan disease either because of that. It's something that is not an uncommon disease. It has a wide range of manifestations. We'll be talking about at least 4 different clinical subsyndromes, which is something you haven't heard about, that in different age groups it looks different and in the way it can present. Early on, at least, it has a remarkable, almost disease-defining response to prostaglandin E2 inhibitors such as ibuprofen. By now, it's clear there are many different triggers, of which group A beta hemolytic strep, which you call SPEGA, the same word, GABS, we call it group A beta hemolytic strep, is probably the most important, but there are many others, including mycoplasma and Coxsackie-B, and we'll look at some data to see relative importance of these. The mechanism seems to be 2 mechanisms working in tandem, both immune in nature. Early on, it's a cytokine mechanism, which is an alternative fever response. And there may be a key finding related to a low interleukin 10, 4, and 13, which produces high interleukin 1 beta and 6, which produces that response. So in other words, these children have an unusual immune system or quirky immune system that predisposes them to this funny response to infection rather than fever and malaise. While all this is going on with the repeated infections that these children have, there is autoantibodies and molecular mimicry going on. And in some cases, the importance of that doesn't manifest for many years of repeated infection. So it has stages, this illness. Disimmunity and immunodeficiency and eventually autoimmunity are common. And this is fundamentally, we had to characterize it a disease of immunology. And we can almost tell that from some of the risk genes that we found, that they tend to be genes that are important in immune function. We can even point now to more specific details, and we'll speak about histamine, which has not been talked about before, as a very important molecule in the basic pathogenesis of the system, and maybe the most important thing linking what's going on one side of the blood-brain barrier to the other. We've been able to implicate several genes as risk factors. This is a multifactorial disease, so it's not like cystic fibrosis where there's one gene, or Duchenne dystrophy where there's predominantly one gene that determines the picture. There are, of course, others in both of those conditions, but predominantly one gene involved. This is definitely not a one-gene disease, but involves risk factors. But the risk factors that we have identified all seem to have a common theme in what they do. So this is basically the way, as of the moment, the way I'm viewing pandas is that it's an interplay between 2 sets of gene risks, one of which are psychiatric risk genes. For example, we have patients that have polymorphisms in a gene called DISC1, which is a powerful schizophrenia gene. Others with COMT polymorph, which is a powerful bipolar gene. And others like Nerexin-1, which is an autism risk gene. So depending on your baseline, the Pandas risk genes seem to interact with that and produce fluctuations in psychiatric symptoms with inflammation. So the a set of genes determines the form of the psychiatric symptoms, and another set of genes, if you have them, determines if those symptoms fluctuate with infection. The psychiatric form, which we don't think necessarily fluctuates. So, in other words, we can have Tourette's syndrome, we can have PANDAS as, or fluctuating Tourette's, which we would call PANS, as separate entities. And the treatment of the psychiatric part of the story is psychopharmacologic agents, and one day, hopefully, gene-specific therapies, where we can actually treat you on a personal basis for the particular genetic problem you have. And the PANDAS risk genes are much more amenable currently to therapy, I think, and can avoid the use of psychopharmacologic agents in children, which is really one of the, really a very important goal, that we don't want to put a lot of young children on Risperdal and SSRI for years so we can avoid it. And the treatment there, as been mentioned, anti-infectives, probably the first line of treatments, if we can identify a trigger or do it rationally. Beyond that, anti-inflammatory therapies, which would begin with non-steroidal anti-inflammatory agents, then steroids, then IVIG, and then perhaps as the final step, plasmapheresis. And of course, that could be changed depending on the severity of presentation. In most cases, there isn't a life-threatening complication of this, in which case you would accelerate to the more aggressive therapies. And of course, in rare occasions, we can identify gene-specific therapies. By focusing on the genetic approach, we can also identify biochemical or metabolic risk factors that are behind this, and there definitely are. So fundamentally, there's metabolic disease or energy metabolic disease that affects the immune system, that affects how we react to infectious agents, and determines whether or not we have these PANDAS symptoms. So ultimately, diet and vitamins, supplements may also play a more important role in this, and can explain why some of the alternative therapies have been somewhat effective. The strict PANDAS model that was described by Dr. Suedo has a few problems with it. Of course, it was a great advance at the time, and always when something happens like this, modifications are made later on. But it was described for research purposes, so it was very precise a definition. We know now, for example, it's not just and Dr. Suedo herself mentioned this, it's not just a pediatric disease. We see it clearly in infants under 3. I think the youngest patient I'm pretty sure had it was 9 months old, but before that it becomes harder and harder to see this because of how do you define OCD in a 6-month-old baby? I don't know if it's possible. I don't certainly know how to do it. So many of the symptoms we're talking about are very, very difficult to recognize in young babies. It is present in adolescents, and it may be present in adults. By that I mean not necessarily a continuation of pediatric symptoms, but actually somebody for the very first time having a symptom like this at age 50. It's very rare. It's probably the rarest group. But I think most people that see a lot of patients with this have recognized a few every now and then. There are many other symptoms besides OCD and tics. It's not just strep. And importantly, the onset isn't necessarily always acute. It might be acute, but some of the symptoms like OCD may easily be, or some of the symptoms that were there may easily be unrecognized. So while we're very happy to see the sudden onset of symptoms, that's very nice to strongly in favor of PANDAS, the absence of the sudden onset of symptoms, or where you're catching this disease, doesn't necessarily rule it out. Generally, there is a rapid improvement with ibuprofen early on in the disease. And because of these problems, there was a convention that was held or a meeting that was held in 2010. This was largely driven by parents in the United States and through the internet. This couldn't have happened 25 years ago, I don't think, where there was sort of a demand please help us. We have these children that have all the symptoms of this, acute onset and these terrible symptoms, and yet are testing negative by throat culture or ASO titers. So the response to that meeting was to redefine the syndrome as, what came out of that meeting was PANS, but you heard that there's another name for it called CANS. In this, notice there's absolutely no mention of infection at all. It is still pediatric, and there's, it allows adolescent cases. It's still classically acute with all limitations there. It's still neuropsychiatric, although it can occasionally have non-psychiatric presentations when urination is the only presentation. That's pretty uncommon, though. So just taking that into account, even this perhaps is not a perfect definition, but it's better than the one we had previously. It includes more children, so that more children that could benefit from the treatment protocols are included. Now, because of in PANS, as you heard, as it's defined by the criteria, the key factor is the sudden onset of OCD. But apart from that, there are many other different symptoms that can happen. So if you look at child 1 on the right with rage and cognitive decline and OCD, he may look very different from the other child who has prominent tics, bedwetting, and anxiety. And the combination that you see in a given child, it's still the same illness, it's treated the same way. So you have to take that into account, that there can be a great deal of variety, not only from child to child, but from exacerbation to exacerbation, so that one child on first time may present with OCD, the second time with tics very easily. We have many examples of that, which leads us to believe it's the same illness. Now, I mentioned that there appear to be syndromes, and this is based on clinical observations in a lot of children. I think most of the people that are here that have seen a lot of patients would more or less agree with this. I hope they would. The first and the last one are the most controversial. This is a big question which is going to take, I think, is just something, food for thought, and is early infantile PANDAS indistinguishable from autism? I think it is, actually. I think if you take all of the symptoms on the PANS list and make them at the highest possible level with an acute onset or relatively acute onset, it would be indistinguishable, especially if it occurred at the appropriate age group from what we diagnose now with autism. Except it's not necessarily autism. It may be highly recoverable autism if the PANS mechanism is playing a role. This is another version of it, which I call the infantile. I'm just putting names on it. These are my names, so you can take them for what they will. Infantile mania syndrome, that's what I see. You'll see the sudden onset of what looks like the worst hyperactivity you've ever seen in a child. These are kids that are jumping on chairs, jumping on windows. They never stop moving. And they're 3 years old. And and it happens suddenly. And what do we do with these children? Maybe the impulse is to put them on a stimulant or SSRIs. One characteristic of this, they do horribly on these meds. They get worse on SSRI and stimulants. Many of these children, if you follow them for periods of time, do develop language regression and late onset PDD-NOS, but it's still PANDAS, and it responds the same way. Now, the syndrome that you're most familiar with that was initially called PANDAS, I call the Suedo syndrome because there are other syndromes that we can now call PANS. I think that's fair to say. It really, as defined, you heard OCD and tics, sudden onset. It would mimic Tourette syndrome in many ways. And that's the group, the PANDAS versus Tourette's in that syndrome. There is also an adult onset syndrome, and I know Dr. Kovacevic doesn't like this, but I call it the Kovacevic syndrome because he first noted this on a web page that he had an adolescent onset form, and it's remarkably accurate, I think. It describes an adolescent child, and maybe he'll talk about it more in his talk, but just to paraphrase what he wrote, an adolescent person who'd never had any problems before, usually an excellent student, excellent athlete, superstar, basically, child. 10th grade, 11th grade, gets often a preceding GI illness of some sort, and then develops sudden, pure OCD and anxiety, usually without tics, and often with depressive features as well. Then something else that I got involved with, which is sort of the mirror image of this, which is called I call the Leroy syndrome, after Leroy, New York, where there was a cluster of girls that suddenly developed in a high school the sudden onset of pure motor tics. I examined about 10 of those girls in that high school, and none of them had any significant degree of OCD. They had other features like postural orthostatic tachycardia, but not that. Now, what would this look like? This would look like a young girl who has all these funny symptoms, and And so it may be confused for a conversion disorder. And in fact, the Leroy syndrome was called the mass psychogenic disorder, which I think is frankly silly, but that's, that's controversial. And as I said, the rarest is the acute onset PANS. Something else that hasn't been discussed here, but I think is also very important, is Pandas has a crisis type situation which mimics a seizure. It's a very sudden onset or exacerbation of symptoms that may last several hours, very characteristic features, and then suddenly shuts off. I call it the exorcist syndrome because that's what parents have been telling me. This looks like the devil is in your child, or somebody else is in your child, very, very suddenly, where the child gets usually a great degree of rage, violent, I would call them ballistic tics, change in voice, so they, or monster sound. They start changing the character of their voice, and it goes away very suddenly, and the child has only a partial recollection of events. Obviously, when we first saw this this was soon after I got involved in Pandas in the late 1990s, we thought it was a strange seizure. But many patients have had EEGs with this. We've never found anything consistent. Although maybe there are subtleties that we, as Dr. Suedo mentioned, there may be some subtle EEG abnormalities in this patient that we missed. But this is terrifying, and these episodes can be dangerous. These kids can hurt themselves and others, so this may be one of the indications that the child has these crises, which are almost like tetralogy of Fallot spells. Not everybody has them, but when you have them, they're dangerous, and maybe an indication for IVIG or plasmapheresis. One thing I've been interested in recently, which we haven't heard about here, is PANS plus. PANS is sometimes seen, all the symptoms of PANS are sometimes seen in the context of a larger illness, and that helps us recognize what's going on in that illness. Some of these illnesses don't have names, so I had to make up a name rather than list all the symptoms, but they're very characteristic. One which is very important to know about is autism plus PANS. People with autism can get PANS. In fact, I don't know if anybody studied this, but I think the incidence of PANS in an autistic population is considerably higher because they already have, a lot going on. So we definitely want to recognize that. The typical story is you have maybe a 7 or 8 year old, mildly mannered, nonverbal autistic child who suddenly develops, out of nowhere, a very severe change in personality. That's not autism getting worse and give more Risperdal, etc. The answer is it's PANS, and it can be treated and readily reversed. I just mentioned this other unusual syndrome, which a number of doctors in the DC area actually are involved in, including some people from Hopkins. It involves the association of Ehlers-Danlos III, which is hyperflexibility, Arnold-Chiari malformation, postural orthostatic tachycardia syndrome, PANS, mast cell activation disorder, and complex regional pain syndrome. It's a relatively common illness in children, and there are a lot of hard features there that are hard to deny unless you look for it. But obviously, what is this going to look like? A somatoform disorder. The child has everything, too many things wrong, and looks like a psychogenic. But there's really illness in there. We're working very hard to identify this subgroup right now. I should mention that immunodeficiency is a very important part of PANS. We know from direct data on 3,000 patients that we've looked at, close to 5% of children with PANS meet criteria for CVID, common variable immunodeficiency disease, which means low IgG, low IgA, often low IgM, and all the subclasses are low, in addition to a poor response to pneumococcal antigens. About 10 to 20% have just a pneumococcal antigen problem alone. That SADNI is a name that stands for selective antibody deficiency with normal immunoglobulins. These people get strep infections and they don't make antibodies. They get the pneumococcal vaccine and they don't make antibodies. So essentially they have a lot of difficulty handling encapsulated carbohydrate-coated organisms, and that's their immunodeficiency. There's a small but important subgroup that has hyper-IgE syndrome. IgE is in the 4,000 range, 3,000, 4,000 range, at least over 2,000 to make that diagnose, to help with that diagnosis, but are not directed against any specific antibody. There are other Pandas variants. Chronic PANS, as we mentioned, And overlap syndromes. An important one to know about is that there's significant clinical overlap with Hashimoto's encephalopathy. Too many of these kids have antibodies to thyroglobulin and antithyroid peroxidase. And symptoms that would be in the Hashimoto's encephalopathy spectrum. If you know anything about Hashimoto's encephalopathy, it's fairly nebulous syndrome too, you know, so we're taking two nebulous things and putting them together. But there is an overlap between the two, and I think that's some of what Dr. Suedo was talking about with some of these autoimmune syndromes. There's an overlap with neurosarcoidosis, believe it or not. Many of these patients have extremely elevated blood and CSF ACE levels and some of the other clinical features of neurosarcoid. And then you mentioned other autoimmune encephalopathies. A fair number of these patients have positive ANAs, and the syndrome that seems to be most associated is the Sjögren's syndrome. And also sleep disorders, you heard a little bit about narcolepsy, perhaps, but there's also an overlap with Klein-Levin syndrome. There are now papers showing that many of those patients, there are a couple of patients with PANS who have developed that as a side effect. So a lot of unusual associations. So I think that this idea of PANDAS is going to make its way into a lot of different areas of neurology. And our work is based on, I'm alone here, so I do this by myself. We saw 3,400 patients in 5 years, and we have really studied them carefully, especially more recently. So we actually have actual data on these patients. I'm just going to look at one of the subsets. So we can look at the actual age distribution in these patients. And this is even clearer when we put the 3,000 patients in. But the distribution is not a bell-shaped curve. It has different components. The most important of which is the adolescent onset, which has a very sharp peak, fairly sharp peak at about 7 to 8 years. Now, this is, of course, the age at recognition, or actually the age at which we think they presented, or when we could define the first symptoms. So that's a little bit nebulous. We need some other markers to tell this. But there clearly is, we believe, also adolescent onset types. I'm just going to say things for speed. Now, this table shows us the relative positivity of various things in 3,000 patients. This is actually 700 patients. We find positive ASO or anti-DNA SPI, either one of those two, in 52%. That's my data. I think people get a little higher number than that. But so a negative TAS or anti-DNA SPI titer does not rule out PANDAS by any means. Then we see positive mycoplasma IgM in 12%. We see positive Cox-Sackie-B titers and now these are titers that are enough to qualify for considered to be active infection. So titers of greater than 32, often much higher than that, in certain Cox-Sackie-B subtypes, especially B5 and B6 are the most important of those. And there may be a biological reason for that. Lyme's, in our hands, at least using CDC criteria, is a relatively small contribution to the picture. So we take all of the possible things. We see a positive ASO and anti-DNA SPI in about 52%, acute mycoplasma in 12%, acute Cox-Sackie-B in about 33%. If we do all these tests, we miss only about 13% of the patients. So usually, if we make the net broad enough, we can find a trigger for PANS, especially in acute onset and early on, in about 80 to 90% of patients. So this is an effective, trigger, because our goal is to try to treat that. I mentioned the Cox-Sackie-B. There's some evidence of a particular importance of that, because there are papers that indicate that Cox-Sackie, particularly B5, has a cross-reactivity with strep, so the body views it the same way. If you happen to have those two infections together, it's a particularly bad situation. 4 minutes, okay. I'll cut to the chase here. What is the list of things that can cause PANS then? I mentioned now, you might be surprised to see, I think on the top of the list is sinusitis. This may be the biggest one of all. And that would include pneumococcus and staphylococcus staph aureus as the greatest, particularly when you get repeated infections of those. Now, many of these patients have immunodeficiency anyway, and a common presentation of many immunodeficiencies is recurrent sinusitis. So it's like a sort of a vicious cycle with this thing. In group A, strep, Cox-Sackie A, and then a number of relatively minor players. But But this is why, for example, we look at this list, for the most part, augmentin is very good in this disease, or cephalosporins, which are good at treating that. Once in a while, we do get MRSA in the staph A, and I'm starting to do nasal cultures rather than throat cultures. I think they may be more helpful in these patients. They're usually more positive. So a high nasal culture with staph, for Staph aureus may be important as well. And sometimes we need to add Zithromax or macrolides to cover the mycoplasma as well. So this is one of the reasons we're interested in the sinus, is this amazing model that Dr. Agalu from University of California, Irvine described a year ago at a conference in Providence, and I think it's just about to be repeated. He takes the mouse and repeatedly introduces either a mouse or rat, I forgot which one, introduces streptococcus and or group A strep and or pneumococcus into the nasal cavity. At first, nothing happens. The mouse recovers. But if you keep doing this, after about 10 to 12 doses, he can actually show in the mouse that Th17 positive cells sensitized to the pneumococcus get into the brain by crossing the cribriform plate, the little bone, the nose bone, and then they follow the olfactory nerve sheath into the brain, and then they distribute themselves there. So if this is true, and if this can be reproduced in animals, this suggests that repeated infections over and over again, not just maybe, sometimes a single one could do it, but most of the time, this type of antibody thing starts predominating again with multiple infections. So,
okay. Dicevo che la relazione del dottor Trifiletti è stata veramente affascinante, cioè vedere come nella PANS possono essere compresi tante situazioni, tante sindromi. Sono rimasto particolarmente affascinato dall'interessamento nei pazienti con Ehlers-Danlos. Io seguo 42 casi di Ehlers-Danlos e una revisione della letteratura ho fatto sulle complicanze neurologiche dell'Ehlers-Danlos, ed effettivamente ho notato però che non solo nella forma tipo 3 ma anche nella forma classica di Ehlers-Danlos ho notato nelle femmine invece una particolare ipercinesia, iperattività. Questa è una cosa che mi è sempre affascinato, perché non sono mai riuscito a capire come mai l'Ehlers-Danlos presentasse una... Ed in merito ancora a quanto ho detto sugli anticorpi di MAR e su queste forme di encefalite, io sono rimasto anche particolarmente colpito perché appunto tanti agenti eziologici virali possono sicuramente contribuire a coinvolgimento, quindi a quello che può essere l'esordio di un disturbo psichiatrico. Io recentemente, pochi mesi fa, ho seguito un caso di una bambina che è venuta di sera in pronto soccorso in un pieno stato di agitazione veramente importante. Bene, ho deciso di fare anche in quel caso un esame del liquor, una coltura del liquor, una rachicentesi, ed abbiamo isolato un HV7, questo qui è un altro virus che va sicuramente cercato, e la nostra attenzione deve essere sempre rivolta anche a questo.
Well, we haven't looked at HHV7, but we have looked at HHV6, and that's another, that's a virus that has been implicated in a lot of different things, and we do see very frequently in exacerbations. And this is based on serum rises in the IgG only. We haven't done spinal taps in these patients. This is on everybody, so it seems to be one of the several potential players on the list. Now, one thing that's obvious here, I'm very disappointed because I didn't get a chance to tell you, really give a very abbreviated talk here. But one very important thing to keep in mind is that why do we get the same syndrome from all these different infectious agents? Can it be that we make antibodies to all these things? That doesn't make a lot of sense to me. I think early on this disease is cytokine mediated, and I can't believe that all these things have cross-reactivity like this. So I think it's going to be important to try to understand how that exactly happens. And then also, genetically, the thing we find that's popping up as risk factors in these diseases, and this is from over 500 patients that we've done complete mitochondrial DNA sequencing and mitonucleomics on, so it's with no presuppositions of what we're going to find, is that we find mutations in antioxidant genes in mitochondria that are very important. Like if you have a mutation in NOS3, which is the intramitochondrial nitric oxide synthetase, your risk of PANS is 30-fold higher than the general population. If there's mutations in the peroxyredoxins, which are another perhaps not as well known antioxidant gene, it's about 20-fold higher. So I don't know if they add together or not, but clearly that must have something important to do with the way the and these are isolated DNA from lymphocytes, so there clearly is something wrong with the antioxidant system in these patients. And so if that's true, maybe even preventive treatment may be available one day. The advantage, of course, of genetic studies that we can identify risk factors is that we have the opportunity of, in the nursery, all right, when the baby is first born, of identifying risk factors for Pandas and maybe coming up with strategies to prevent this disease entirely. I mean, that's a long way off, but really genetics gives us that opportunity, whereas a lot of these other things, you have to wait till the child gets to a certain age to determine if they have the disease. And by then it may be, already, well on its way. So that's one reason we focused on that. And I'm sorry I didn't have a chance to talk more about it.
Bene, dobbiamo rispettare assolutamente i tempi, c'è spazio solo per una o massimo 2 domande. Prego.
I am the mother of a pandas child. What about antiviral agents in PANS? Because my son, using antivirals, could eradicate eye rolling and this shoulder tick.
It's very heretical right now that the Coxsackie virus can be treated with acyclovir and Valtrex. It does respond amazingly well. That's not what the textbook says. There's no treatment for Coxsackie B. Yet the levels come down, the patients get better, all of the symptoms disappear. I think there is precedent for it. There's reason to believe that might work by increasing interferon levels rather than directly on the virus, which means in some ways, the inflammatory effects of antibiotics work on viruses as well. But I do give patients Valtrex if we determine they have Coxsackie B infections, and very often they get much better when nothing else works. So it's definitely out of the box. I would never be able to do this in an institution, but it does work, and we carefully monitor those patients. Thank you.
La parola alla dottoressa Cunningham per una domanda.
Just a comment to Dr. Trifiletti. I know that he always challenges cross-reactivity, but I would refer you, I guess, with your comment, you said that you couldn't imagine all these cross-reactivities. So I would like to just refer you, since you brought up Coxsackie virus, to our 1990 Proceedings of the National Academy of Sciences paper on antibodies against the streptococcus that actually neutralized Coxsackie virus, and then a subsequent PNAS paper that went on to state that, or show that these same antibodies actually create Coxsackie viral escape mutants, so that they actually change and undergo antigenic variation. And I would like to say that cross-reactive antibodies are part of our normal immune system. They help protect you against infections. It's when they go awry that unfortunately you get misdirected antibody responses against the host tissue. But the Voyage of the Beagle by Darwin is not by accident. He actually discovered evolution, and part of that is that survival of the fittest. And what we've done in our immune systems is we have developed them so that they protect us against a variety of immune agents, or we would all be immunodeficient and die. It wouldn't work. And so cross-reactivity is very important, not only normally in our immune responses, but then unfortunately sometimes it can actually cross-react with tissues. So I know that you are not so
Oh
keen
no, I'm
on
big.
the-
I'm totally with molecular mimicry. I think it's just there are two mechanisms going on
Well,
at
I
once.
do too, and I wanted to say that yes, the molecular mimicry part or the cross-reactivity is adaptive. For us that are academics, there are two types of immunity. There is the innate immune response and the adaptive immune response. And the antibodies are the adaptive immune response that comes from B cells. And that's why rituximab works, is because you kill the B cell that's making the antibody. But what Dr. Trifiletti is referring to is early on in the disease, or just early on, any time you have inflammation, you have an innate immune response. And this innate immune response can be your cytokines, it can be complement, it can be any number of responses that you make acutely. And so why a patient may get better overnight may be because the innate immune response has been dampened.
Right. And, you know, just in line with the Coxsackie-B, there's also a paper or two now showing that Coxsackie-B can mimic most of the effects of Sydenham's chorea, right there, that you get the myocarditis and even chorea from Coxsackie-B infection. So the analogy holds all the way down, you know. It's not, obviously not as common as strep for that, but it does happen. Yeah.
Thank you.
Bene.